The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Bryan Meyers here to review the management of all things esophagus.
Yeah, thanks. I'm Bryan Meyers. I'm a member of the thoracic surgery faculty here at Washington University, and I've been a member of that faculty since 1998 when I finished my training here. I'm really happy to be part of this process after several years of helping edit chapters for the Washington Manual of Surgery. I'm pleased to take this new step into a different dimension of education.
Hi, Dr. Meyers, and thank you again for joining. Let's dive right into a case scenario to guide our discussion. So for our first case, a 67-year-old woman has recently been discharged from the hospital after being treated for aspiration pneumonia. She's referred to your clinic after follow-up with her PCP, who's concerned about her worsening ability to swallow food. When you obtain a history, she says it started with getting a pulled pork sandwich stuck in her throat at her sister's birthday party about a year ago. She now has trouble keeping down liquids without vomiting a small amount at night. What's your initial workup?
Well, first of all, I'd commend her on the clarity of the chief complaint. The details of the pulled pork sandwich and the birthday party are nice added benefits to the history. But I think any problem like that, you're going to probably want to start with a contrast swallow. I think for me, contrast swallow is a nice roadmap. It's not an invasive test. It doesn't hurt. It's relatively cheap, and it just really gets you headed down the right path. Once you've had the contrast swallow, then almost certainly in a patient like this, you're going to follow up with an endoscopy. And in many cases, if you're viewing it from the point of view of a surgeon, that might already have taken place by the time they see you. But I think the combination of those two things are going to get you well along the path of making a diagnosis and formulating a plan.
There are a lot of disorders that can be sussed out with manometry as well. Walk me through some of the high-yield findings there would be and which diseases they might correspond to.
Oh, sure. So when someone has difficulty swallowing, the manometry is going to help you quite a bit. I think the real mainstay that you're looking for is achalasia, and I always educate my patients to inform them that there are two main deficits with achalasia. The one is the absence of peristalsis, and the other one is the failure of the lower esophageal sphincter to relax. And both of these would be identified most clearly at the time of manometry. Now, there are other problems that can be clarified with manometry, but I think those two findings, the presence or absence of peristalsis and the degree of relaxation of the lower esophageal sphincter are the main things you're going to be looking at in a situation like this.
And let's say we do get the barium swallow and it shows that classic bird beak sign, and manometry supports a diagnosis of achalasia. How rare is achalasia?
I believe that the incidence of achalasia is probably about 1 in 100,000 in the United States. And so 1 in 100,000 per year. So that's relatively rare compared to a lot of the other conditions that we ended up treating in thoracic surgery. The prevalence is about 10 times that. So 10 out of 100,000 at any one time are sporting a diagnosis of achalasia.
And what are the initial treatment options for a patient with achalasia?
Well, so typically, because of the two problems that I mentioned to you, the absence of appropriate peristalsis and the presence of an unrelaxing lower esophageal sphincter, those two things together cause the symptoms, but we're always quick to point out to patients and referring doctors that we can only surgically address the second of those two things. So almost always there's going to be some attack on the non-relaxing lower esophageal sphincter. And for years, that's been appropriately a laparoscopic hilar myotomy. But for the last several years, there has been an ascendancy towards equality of a different strategy called POEM.
Yeah, so tell me about POEM. How does that work?
Well, POEM is a very novel strategy that has been devised and honed over the last several years, and it's not the easiest thing for patients and possibly for physicians to get their head around. But it involves doing an endoscopy, and then during the endoscopy, saline is injected underneath the mucosa to elevate the mucosa off the underlying muscle. And then an incision is made in that elevated mucosa, and a tunnel is created along the remaining length of the esophagus, all the way to the upper stomach. Then the endoscopist comes back about 3/4 of the way towards that mucosotomy, and then uses electric energy to cut the muscle from that point down to the stomach. You remove the scope from the tunnel and then put some clips on the mucosa, and you've achieved almost the same outcome as a surgical myotomy, but you've done so without any skin incisions. So it's really a single orifice approach at a Heller myotomy, and the fact that it actually works is still, I think, amazing.
Very interesting. Let's move on to our second case. A 51-year-old gentleman presents to your clinic with a long-standing chest pain that has gotten worse in the last few months, along with shortness of breath while he's doing yard work. He used to take Tums a few times a week and now takes it several times a day. He occasionally has trouble swallowing burgers and sandwiches. What are some of the things you would like to know on a history and physical, and is there any additional steps right now that you would like to take?
Well, I think when you have somebody that age who's having trouble swallowing, you have to consider all possibilities, and those would range from a hiatal hernia to a stricture to a cancer and to a motility disorder. So the esophagus is a very simple organ that connects the mouth to the stomach, and when problems happen, it almost always results in some degree of dysphagia. So you'd really want to learn a little bit more history, and learning more about the history of heartburn or the presence of any known previous CAT scans. There's a lot of times patients will have a hiatal hernia or a diverticulum lurking in some previous CAT scan that was obtained for some other reason, and it's only in light of the new symptoms that it becomes important. So you want to gather up all your history from the memory of the patient, history from any studies that have already been done, and then plan your strategy for a diagnostic workup.
You get a barium swallow, and it shows a sliding type 1 hiatal hernia. What's the most common presentation for hiatal hernias?
Well, I think that probably the most common presentation is going to be a patient with severe reflux presenting to a gastroenterologist for guidance of management of the reflux, and then an endoscopy is performed to assess the esophageal symptoms, to screen for esophagitis, screen for Barrett's, and the hiatal hernia is detected that way. Probably the most common presentation of hiatal hernias in general is no presentation, because there's some estimates that suggest that as we age, the fraction of our population that sports a hiatal hernia increases almost to the point of 40 or 50% by the time we're in our 80s or 90s. But the majority of patients are asymptomatic or minimally symptomatic. So it's really the tip of the iceberg, the squeakiest wheel that ends up getting endoscopy or getting a diagnosis of a hiatal hernia. And I think we always got to keep that in mind when we're counseling patients with regard to management of the hiatal hernia.
And let's turn our attention to Schatzki's rings. What are they, and what is their relationship to hiatal hernias?
Yeah. So, what are your thoughts about Schatzki's ring? That's a nice eponym. It's something that the listeners want to kind of put away in the back of their brain and understand. The Schatzki ring is almost always associated with some sort of esophageal or esophageal gastric pathology, and most commonly it's going to be a hiatal hernia because that is such a rare or such a common condition anyway. But the pathogenesis of a Schatzki ring or the significance of a Schatzki ring is a little less certain. I think in general there might be they might be an incidental finding, where the reflux and the symptoms of the hiatal hernia, other than the Schatzki ring, are the thing that's driving the patient's quest for treatment. And sometimes the Schatzki ring might be the holdup of swallowed material that leads to the detection of the hiatal hernia. I think they're an interesting association, but they end up being more of an add-on to the underlying pathology that they're associated with.
When are you ordering CTs for hiatal hernia patients?
I'd say that often patients are sent for referral for evaluation of a hiatal hernia with a CT in hand. So for the initial workup nowadays, many times the CT has already been obtained before I even get my hands on the decision-making process. But I think that if somebody has a recurrent hiatal hernia, I'm very interested in a CT scan. If they've had multiple previous surgical procedures, I really want to know what's happening there above and beyond what you could learn or obtain from a contrast swallow. I just think that if somebody has unusual symptoms or some evidence of a type 4 hernia, I think those are things that would trigger me to consider a CT scan. Otherwise, if somebody had GERD and they were felt to have a hiatal hernia and they didn't have any imaging yet, once again, I think I would probably lead off initially with a contrast swallow, just because it also has a live element to it. You get some videos, you get a little bit of a sense of the motility, and so there's some extra value there that you don't see with the static images of a CT scan.
I like what you were saying there about how different hiatal hernia types aren't all the same. So let's walk through the types of hiatal hernias. How does knowing each type affect your management?
Well, first of all, I think if for the listeners, if they're still in their training, this is a prime question for rounds. I think that anytime there's a dichotomy or there's a short list, I think the active learner is going to want to know those classifications. But typically, and there are some variations the way people describe things, but the most simple hiatal hernia is a sliding hiatal hernia, and that's where the GE junction resides above the diaphragmatic hiatus rather than a centimeter or so below the esophageal hiatus. A type 2 hernia is exceedingly rare. That's where the GE junction is below the hiatus, yet a portion of the fundus is above the hiatus. And I've maybe seen a couple of those in my career, and in many instances, there's some malformation of the diaphragm where there's a band of a crura that's in their normal location, but there's an absent piece of diaphragm just next to that allows the fundus to kind of rise up above the diaphragm while the GE junction remains below. They're so rare that you could almost eliminate that from the classification scheme and not feel you're missing anything out. Type 3s are probably the most common that I see, and that's where the GE junction is above the diaphragm, but then you have some fundus above that up in the chest, and sometimes that can be so extreme that the entire stomach is up in the chest, and that would be kind of the limit of what a type 3 hiatal hernia could be. And then type 4, we generally kind of lump in all the hernias that are likely type 3s plus the addition of some other organ, whether it's small bowel, colon, sometimes pancreas or spleen. But probably the most common additional structure that gets brought up there is the transverse colon, because it's just right there knocking on the door as the stomach is sliding up.
And we have a couple different surgical options for fundoplications. Let's talk through each one of them and when you might use one.
Yeah, sure. So again, this is a march of the eponyms, and I hope we're honoring the right people when we associate the names from decades or even centuries ago with an operation. But probably the most common operation that's done is the Nissen, and that's a 360-degree wrap where you take a hiatal hernia or take a reflux in the absence of a hiatal hernia, and you free up the fundus and you wrap it 360 degrees, generally with a bougie in the esophagus at the time of the wrap to prevent you from making the wrap too tight. The next one down on my mental list would be a toupee, and that's where almost all the same steps occur, mobilization of the GE junction, freeing up the floppy tip of the fundus, but the difference between a toupee and a Nissen is that you stop at about a 270-degree wrap rather than a 360-degree wrap. And that might be in a situation where the motility that was measured at the time of manometry suggested that a complete wrap might be too tight. So you can get away with a toupee or a partial posterior wrap with patients who have very limited motility. Even with patients who have achalasia and no motility will do okay with a partial wrap, whereas if you do a complete 360-degree wrap, you might be asking for trouble and dysphagia. A door wrap is an anterior partial wrap, and I think in my practice, I would really limit that to an anti-reflux wrap after a halar myotomy. And sometimes we're guided, by early events in our career, and we tend to be guided more durably by negative events. And I think I had a couple door partial wraps that reherniated quickly early on in my career, and I felt that was something I didn't really want to have happen too frequently. And so I, for the most part, other than in patients who have a halar myotomy, I've abandoned the door, and I would stick with a toupee as a partial wrap in a patient with otherwise intact esophagus. And then, so those three, the Nissen, toupee, and door, would probably get you through a big portion of the pie chart of anti-reflux or fundoplications. If you threw in the Belzy, which is a transthoracic one of almost historical importance only at this point, and a Hill, which is worth some extra reading on the side for the interested listener, then you really rounded out the main suspects there for fundoplications.
And what does it mean to do a callus gastroplasty? What pushes you in that direction?
Well, so because in my practice, a lot of the hiatal hernias I take care of are big type 3 hiatal hernias. I think that, and there also is a tradition or a tendency, I think, for thoracic surgeons to embrace callus gastroplasty more so than general surgeons. I tend to do a lot of callus gastroplasties, and so the way that the operation was devised in 1957 by Collis was to treat what he felt was an irreducible hiatal hernia. And so at that time, before proton pump inhibitors and other medications to reduce the inflammation associated with reflux, the chronic hiatal hernia also led to transmural scarring of the esophagus, and that transmural scarring led to shortening of the esophagus. And so if you tried to reduce the hiatal hernia and create at least a couple centimeters of intra-abdominal esophagus in a patient who had chronic reflux and inflammatory shortening of the esophagus, you would find that would be impossible. That was the premise of Collis's device of this operation. So what Collis did was to put clamps on the stomach adjacent to the lesser curvature, and he would make a cut and then oversew in a V-shaped formation to create a tube of stomach that was the same diameter as the esophagus that it was immediately following, and it was generally about 3 or 4 centimeters long. So you're essentially adding 4 centimeters of length to the esophagus. Now the whole cutting and sewing thing has been left in the dust by Staples, and so if you were to do a cholecystroplasty from the belly, which is where I would normally do it, it usually takes the form of what's called a wedge fundectomy. And so you put a bougie in the stomach through the esophagus. You have the bougie hug the lesser curvature of the stomach, and then you take a small triangle of stomach out adjacent to the bougie, and in so doing, you create this tubular extension of the esophagus. I still find it useful, to add length in patients who have a long-standing large hiatal hernia. But I would say that there are people who have excellent results with perhaps more time and effort spent mobilizing the esophagus and creating length in that manner. And it's just really what somebody's comfortable with.
We hope you enjoyed this installment of the Washington Manual of Surgery podcast. Stay tuned for part 2 of this episode to learn more about Barrett's esophagus, diagnosis and treatment of esophageal cancer, and managing esophageal emergencies. We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.